Welcome back to the Deep Dive. Today we are shifting gears a little. Usually we take a topic and explore it purely for the joy of learning. But today, the stakes are different.
Oh.
I want you to imagine the clock is ticking, the coffee is cold, and the books are piled high. We are stepping into the shoes of a postgraduate student, specifically preparing for the Gujarat University MD anesthesiology exams.
That is a very specific high-pressure scenario. I know it well. The Gujarat University exams are known for being rigorous, particularly when it comes to the fundamental concepts of, physiology and pharmacology.
Exactly. And to help me survive this imaginary but very stressful scenario, you are stepping into the role of the senior MD faculty. You are the professor who has seen generations of students pass and fail, and you know exactly what the examiners are hunting for.
I accept the challenge, and looking at the source material we have today, we're very well armed. We have the heavy hitters: Miller's Anesthesia 10th edition, Morgan and McHale, Stolting's Pharmacology, plus specific inputs from Yao and Artuzio and the ICU book. This is the gold standard stack for any postgrad.
Our target is preemptive analgesia and recent modalities in pain management. Now, to be honest, when I see this topic on the syllabus, I feel a bit of dread.
I understand.
It feels like one of those topics where the definitions are slippery and the textbooks seem to contradict each other depending on which edition you read.
That is a very common feeling, and actually, that confusion is exactly where the examiners will try to catch you. It's a classic Viva trap.
Okay.
If you go into the exam hall quoting a definition from 1990, you might be historically accurate, but you will be clinically wrong by modern standards. The real secret here, the key to getting those extra marks, is understanding the narrative arc.
The narrative arc.
Yes. You need to understand why preemptive analgesia was the buzzword of the 90s, why it technically failed in many clinical trials, and how it has evolved into the modern gold standard of preventive analgesia.
Okay, so let's build that narrative. If I get a long question on the evolution of pain management, I can't just start listing drug dosages. I need to set the scene. How has the philosophy changed?
You need to start by contrasting the old way with the new way. Historically, anesthesia was very reactive. It was the PRN, model pro renata, or as needed.
Right.
The patient wakes up, they scream in pain, and only then do we administer an opioid. It was an opioid-heavy reactive model.
Which implies we were chasing the pain rather than getting ahead of it.
Precisely. We were playing catch-up, and Miller makes a very strong point about this. Modern anesthesia has shifted from that reactive model to a proactive model. We are no longer just treating pain, we are anticipating it.
Right.
We're trying to prevent the neurobiological changes, the wiring changes in the spinal cord that make pain chronic.
I've heard the analogy of putting out a fire versus fireproofing the building. Is that too simplistic for an MD exam?
Not at all. It's the perfect analogy to explain the concept conceptually before you dive into the molecular details. An examiner would appreciate that clarity.
Okay.
Treating pain after the patient wakes up is like trying to put out a fire that has already engulfed the house. You might put it out, but there is going to be damage, smoke damage, structural damage.
And in this analogy, the structural damage is central sensitization.
Exactly. That's the perfect term. Preemptive and preventive analgesia are about fireproofing the building before the spark even happens. You are modifying the nervous system so that the fire never really takes hold.
Okay, that gives me a solid opening paragraph for an answer. Now, practically speaking, for the Gujarat University exams, how does this topic usually appear? I need to know the enemy.
You will likely see it in three forms. First, the short note, a classic 5-mark question. Write short notes on preemptive analgesia. Here, brevity and precision are key. You have to be sharp. Second, the long question, usually 10 to 15 marks. Discuss the pathophysiology of pain and recent advances in management. That is where you need to bring in the ultrasound and the new drugs. Show your breadth of knowledge.
And the Viva, that's where I feel most vulnerable.
The Viva, or OSCE, is where they test your concepts and your equipment knowledge. They're not just testing what you've memorized. They might ask, what is the difference between preemptive and preventative? That is a classic trap we just talked about.
Okay.
Or they might hand you an ultrasound probe and ask you to demonstrate the physics behind a plain block. They want to see if you understand the neurobiology and not just the drug doses.
All right, let's tackle that classic trap first. The definition. If I'm writing the exam, how do I define preemptive analgesia without getting it wrong?
The classic definition, going back to Wolff in the early 1980s, is very, very specific. It is the administration of an analgesic intervention before the surgical incision.
Before the cut.
Yes. The hypothesis was that if you block the afferent input before the cut, You prevent central sensitization, and the patient will have less pain after the surgery compared to a patient who got the same drug after the incision.
So a straightforward study design. Group A gets the drug 5 minutes before incision. Group B gets the drug 5 minutes after incision. If Group A has less pain post-op, then preemptive analgesia works.
That was the theory, and biologically it makes perfect sense. But here is the exam core nuance you need to write down. Miller, in Chapter 77, clearly states that when they did large-scale clinical trials testing this strict definition, the results were, well, equivocal.
Equivocal?
Yes, sometimes it worked, sometimes it didn't. There was no consistent, powerful effect.
That seems counterintuitive. If the biology is sound, if we block the signal, why didn't the trial show a massive benefit?
Because the definition was too narrow, it was flawed. The preemptive concept focused only on the incision. But does tissue damage stop after the incision is closed?
No, definitely not. You have inflammation, you have drains, tissue retraction, the whole healing process. The body is still, screaming.
Exactly. The barrage of nociceptive input pain signals continues well into the postoperative period. So if your preemptive block wears off in 4 hours, but the inflammatory response lasts for 48 hours, the spinal cord eventually gets sensitized anyway.
So the fireproofing wore off while the fire was still trying to start?
That is the perfect way to put it. And this failure of the narrow definition is what gave birth to the preventative concept. This is the term you must use to get high marks.
Preventive analgesia.
Preventive analgesia is broader. It means blocking noxious stimuli across the entire perioperative period, pre-op, intra-op, and post-op. It's not just about when you start, it's about covering the entire duration of the injury.
I see. It's about duration, not just initiation.
Precisely. So if an examiner asks you in the Viva, does preemptive analgesia work? You shouldn't just say yes.
Because it's a trap.
Yes, that's a trap. Your safe, distinction-level answer is, the narrow definition of preemptive analgesia showed mixed results in clinical trials because it failed to cover the post-operative inflammatory phase.
Okay.
However, the broader concept of preventive analgesia is the current clinical standard and has strong evidence for reducing chronic post-surgical pain.
That sounds authoritative. I like it. Now, we've used terms like sensitization and fireproofing, but for a 15-mark answer, I need to drill down into the mechanism. I need to explain the pathophysiology.
Absolutely. You cannot answer this question without discussing the inflammatory soup and the wind-up phenomenon. These are non-negotiable keywords.
Okay, let's start at the skin. Peripheral sensitization. What is happening when the scalpel hits?
When you damage tissue, cells rupture. They release a cocktail of chemicals, right into the interstitial fluid.
The inflammatory soup.
Exactly. And you should name the ingredients: bradykinin, prostaglandins, serotonin, potassium ions, hydrogen ions. Morgan and Mikhail describes the triple response of Lewis here, the flush, flare, and wheal you see on the skin.
And what does this soup do to the nerve endings?
It lowers their threshold. It's like turning up the sensitivity on a microphone. A stimulus that wouldn't normally hurt, like a light touch, might now trigger a pain signal. That's allodynia. Or a painful stimulus hurts much more. This is primary hyperalgesia.
So the signal is amplified right at the source. Then it travels up the A delta and C fibers to the spinal cord. This is where the real action is, right? The dorsal horn.
Correct. The dorsal horn is the relay station, the first synapse, and specifically you have to mention the wide dynamic range, or WDR, neurons.
So WDR neuron, okay.
Now, under normal circumstances, if you poke your finger, the WDR neuron fires once. You feel a poke. But if you have a continuous barrage of firing C fibers like from a surgical incision, something changes in that neuron. It starts to get, well, excited is an understatement. It becomes hyperexcitable.
This is the wind-up phenomenon.
Yes. Wind up. And for the marks, you must describe it as a progressive increase in the discharge frequency of the WDR neurons in response to repetitive C fiber stimulation. But you can't stop there.
Okay, what's next?
You have to explain the receptor mechanism. You have to mention the NMDA receptor.
And methyl deaspartate. I always struggle to visualize this receptor. I know it's involved in memory and pain, but what is it actually doing?
Think of the NMDA receptor like a door that is normally locked. It's a ligand-gated ion channel, but it's also voltage-dependent.
So it needs 2 keys to open.
Sort of. Under resting conditions, this receptor is physically plugged by a magnesium ion. It's like a bouncer standing in the doorway saying, no entry, even if the neurotransmitter glutamate is knocking.
So magnesium's the bouncer. I can remember that.
Yes. But with sustained depolarization, that constant barrage from the C fibers we talked about, the electrical charge of the membrane changes. This electrostatic repulsion literally kicks the magnesium plug out of the channel.
And once the bouncer is gone.
The floodgates open, calcium rushes into the cell, and calcium is a powerful second messenger. It's an excitotoxin in high concentrations. It activates intracellular pathways that permanently ramp up the gain on the amplifier. Well, for a long time. It causes long-term potentiation. Now, the WDR neuron is hyperexcitable. It will fire at the slightest provocation. This is central sensitization. This is why a patient might still be in agony days later, even if the wound looks fine. The spinal cord has learned the pain.
That is a terrifying concept, actually. The nervous system remembering the trauma.
It is. It's neuroplasticity, but in a harmful way.
Yeah.
And that connects to the gate control theory by Melzack and Walt. You have to quote the date, 1965. It's a classic.
Right.
The idea is that we can modulate this entry. Large fibers, A-beta, which carry touch and pressure, activate inhibitory interneurons in the substantia gelatinosa, effectively closing the gate to pain transmission.
Whereas the small C fibers open it.
Exactly. They inhibit those inhibitory interneurons. So that's why rubbing your elbow after you bang it helps. You are stimulating A-beta fibers to close the gate.
Okay, that makes sense.
And anesthetically, our entire goal with preventive analgesia is to keep that magnesium plug in place and keep that gate closed so the windup never happens.
Okay, we have the theory down. It's solid. Now let's talk practical methods. How do we stop this train? How do we fireproof the building?
There are three main buckets you should mention in your answer: pharmacological, regional, and multimodal.
Pharmacological seems straightforward to giving drugs.
Yes, but specifically giving them before the injury. NSAIDs, opioids, NMDA antagonists. But if you want to impress the examiner, you need to emphasize regional techniques.
Why does regional win over just giving IV drugs? What's the core advantage?
Think about the pathway we just drew. The pain pathway has 4 steps: transduction, transmission, modulation, and perception.
Right.
High-V drugs mostly work centrally on the brain, perception, or the spinal cord, modulation. But regional anesthesia, like a nerve block or an epidural, blocks the transmission entirely.
Ah, it hits an earlier step.
Exactly. If you put local anesthetic on the nerve, the electrical impulse, the action potential never reaches the spinal cord. The spinal cord never knows the surgery is happening.
So total silence in the dorsal horn. No repetitive C fiber firing. So no windup because there is no signal to kick out the magnesium.
Exactly. That is why regional is considered the most effective form of preemptive, or rather preventive analgesia. It is a complete afferent blockade. It's like cutting the cable.
Let's talk about the specific drugs quickly because examiners love asking about mechanisms. Start with NSAIDs.
NSAIDs, diclofenac, ketorolac. They work peripherally at the site of transduction. They block cyclooxygenase, or COX, enzymes.
COX-1 and COX-2.
Right. If you block COX, you stop the production of prostaglandins from arachidonic acid. So you are essentially neutralizing a key ingredient of that inflammatory soup we talked about.
So they reduce peripheral sensitization.
Yes. Miller notes that while they have some preemptive effect, their real value is in reducing the inflammatory response post-op, so their timing is less critical than their continued use.
What about opioids? I thought we were trying to avoid them in modern practice.
We are sparing them, not eliminating them entirely. They're still a powerful tool. Opioids bind to mu receptors in 2 key places. First, in the periaqueductal gray, or PAG, in the midbrain.
Okay.
This activates the descending inhibitory pathways. The brain sends signals down to the spinal cord telling it to calm down. Second, they act directly on receptors in the dorsal horn, inhibiting the release of substance P.
So they work on modulation.
Primarily. But there is a massive nuance here you must mention. Opioid-induced hyperalgesia, or OIH.
That sounds paradoxical. Opioids causing more pain.
Yes, it's a real phenomenon, especially with high doses of ultra-short-acting ones like remifentanil. They can paradoxically activate pro-nociceptive pathways, possibly involving the NMDA receptor system as well. So the patient wakes up more sensitive to pain than if you hadn't used them.
Which is a huge argument for multimodal analgesia.
The #1 argument is why we don't just blast them with fentanyl anymore. And then there is the specific antidote to wind-up: ketamine.
The NMDA receptor antagonist.
Precisely. Remember that magnesium plug. Ketamine essentially does the same job. It's a non-competitive antagonist. It binds inside the NMDA receptor channel and prevents calcium influx, even if the magnesium plug is gone.
But we aren't using anesthetic doses, right? We don't want them dissociating or hallucinating in recovery.
No, absolutely not. That would be a disaster. We use a subanesthetic or analgesic doses, typically a bolus of 0.15 to 0.25 milligrams per kilogram, followed by a small infusion. Just enough to block the receptor, not enough to cause significant psychomimetic effects.
Okay, so we have the drugs, we have the theory. Does this actually translate to patient outcomes? What's the clinical application?
Ideally, yes. The metrics we look at are post-op pain scores, like the VAS or NRS scores, and opioid consumption. The goal is an opioid-sparing effect.
Right.
But the holy grail, and Miller discusses this in the context of thoracotomies and amputations, is the prevention of chronic post-surgical pain, or CPSP.
Chronic pain after surgery is a huge issue. Phantom limb pain, post-thoracotomy pain, post-mastectomy pain.
It is. It's a devastating complication. And there is growing evidence that an effective blockade, like an epidural or a paravertebral block, placed before the ribs are retracted or the limb is amputated, can significantly reduce the incidence of that chronic pain months, even years later.
So it's not just about a comfortable recovery room stay.
Exactly. You aren't just treating them for the day, you are potentially treating them for life. That's the ultimate selling point for doing this properly.
That is a powerful argument. Now let's pivot to the recent modalities part of the question. If I am sitting in the exam hall today, what is the headline for recent advances? What's the big story?
The headline is the paradigm shift. We have moved from an opioid-centric monotherapy model to a multimodal opioid-sparing strategy.
Why? What drove that shift?
The opioid crisis, for one, but also a recognition of the ORA's opioid-related adverse events. Every anesthetist knows them. Respiratory depression, nausea, vomiting, Ileus, sedation, urinary retention, pruritus. The list goes on. So the modern anesthesiologist uses a toolkit, not just a hammer. And the biggest, most game-changing tool in that kit recently is ultrasound.
This is exam gold, ultrasound-guided regional anesthesia. I need to be able to talk about this with some authority, even if I haven't done 1,000 blocks myself.
You do. You need to know the physics and the safety profile. First, probe selection. For superficial structures, like the brachial plexus and the supraclavicular region, we use high-frequency linear probes 10 to 15 megahertz.
High frequency gives better resolution but less penetration.
Correct. For deep structures, like a sciatic block in a gluteal region, you need a curvilinear probe with lower frequency, maybe 2 to 5 millihertz, to penetrate the tissue.
And what are we looking for on the screen? What is the buzzword description of a nerve on ultrasound?
The honeycomb appearance. The fascicles are dark hypoechoic, and the surrounding connective tissue, the epineurium, is bright hyperechoic. But here's the viva trap. Anisotropy.
Anisotropy. That's the phenomenon where the nerve seems to disappear if you tilt the probe, right?
Yes, precisely. Nerves are highly anisotropic. If your ultrasound beam isn't hitting the nerve at a perpendicular 90-degree angle, the sound waves reflect away from the probe instead of back to it. The nerve looks black, just like a blood vessel.
Which is dangerous. You might think it's a vein and avoid it, or worse, think it's just muscle and drive your needle right through it.
Exactly. So understanding anisotropy shows the examiner you know the practical pitfalls. The main advantages of USG over the old landmark or nerve stimulator techniques are, first, direct visualization.
You see what you're doing?
Yes. You see the needle, you see the nerve, you see the surrounding structures like arteries and the pleura, and crucially, you see the spread of the local anesthetic in real time.
And Miller mentions dose reduction here too.
Yes, this is a key point. Because you can place the drug precisely in the fascial plane around the nerve, you can use significantly less volume.
Which means less risk of toxicity.
Right, a lower risk of ASTI local anesthetic systemic toxicity. Plus, you can visually see the vessels and avoid them, drastically reducing the risk of intravascular injection. And for blocks near the chest, you see the pleura, which makes pneumothorax a much rarer complication.
Ultrasound has also opened up a whole new class of blocks, the fascial plane blocks.
These are very trendy right now, and you should definitely mention them. TP blocks, which is the transversus abdominis plane block for abdominal surgery, or ESP blocks, the erector spinae plane block for thoracic and abdominal analgesia.
And these are different from traditional nerve blocks.
They are. These are volume blocks. You aren't necessarily targeting a single nerve sheath. You are injecting a larger volume of local anesthetic into a fascial plane where multiple nerves run, and relying on the volume to spread and bathe those nerves. You simply couldn't reliably do these blocks blind.
Okay. Let's briefly touch on catheters. Continuous peripheral nerve blocks.
This is taking the single shot block and extending its duration for days. You thread a catheter, just like an epidural, but next to a peripheral nerve like the femoral nerve for a knee replacement, or the interscalene brachial plexus for shoulder surgery.
What's the main benefit there?
It's huge for orthopedics. Imagine a total knee replacement patient. The physiotherapy is aggressive and painful. If they have a continuous femoral block, they can participate fully in physiotherapy without agonizing pain on day one. It dramatically speeds up recovery.
And for ambulatory patients sending them home, we use those elastomeric pumps.
The pain balls or on-cue pumps, yes. They utilize a vacuum or positive pressure to deliver a fixed rate of local anesthetic so the patient can go home with the catheter in place. It's a game changer for daycare surgery.
Moving on to newer pharmacological modalities. We talked about ketamine. What about alpha-2 agonists? Dexmedetomidine and clonidine.
These are crucial adjuvants in the multimodal toolkit. They act on alpha-2 receptors both centrally in the locus coeruleus and spinally in the dorsal horn.
What is their main advantage over, say, opioids or benzodiazepines?
They provide analgesia and, importantly, a cooperative sedation without significant respiratory depression. That is the key. Patients are rousable, they maintain their airway reflexes, but they are calm and pain-free. It simulates natural sleep.
And they have a role in blocks as well.
Yes, they prolong the duration of nerve blocks if you add a small amount to the local anesthetic mixture. They cause local vasoconstriction and have a direct analgesic effect on the nerve.
And then we have the gabapentinoids, gabapentin and pregabalin.
These are essentially membrane stabilizers. Now, memorize this receptor target for your exam. They bind to the alpha-2 delta subunit of voltage-gated calcium channels.
Alpha-2 delta subunit. Got it.
By binding there, they stop the trafficking of these channels to the cell surface. This inhibits calcium influx into the presynaptic nerve terminal and reduces the release of excitatory neurotransmitters like glutamate and substance P.
So we use them preoperatively.
Yes, preoperative oral dosing helps reduce anxiety and has been shown to reduce post-op opioid requirements. They are particularly good for surgeries known to cause neuropathic pain.
What about 5-Vitacaine? I see this being used more and more for major abdominal surgeries.
Yes, an IV lidocaine infusion. It's sometimes called the poor man's epidural. It's fantastic for visceral surgery, especially bowel surgery.
Why is it so good for that?
It has multiple properties. It's analgesic, it's anti-inflammatory, and, this is important, it has prokinetic properties. It actually helps the bowel wake up faster, reducing post-operative ileus, which is a major cause of prolonged hospital stay after abdominal surgery.
Let's zoom out a bit. Interventional techniques. This feels more like chronic pain management, but it overlaps with our role as anesthesiologists, right?
It does. And remember, the anesthesiologist is a perioperative physician and often a pain medicine specialist. This is part of our scope. We use techniques like radiofrequency ablation or RFA.
Where you essentially burn the nerve.
It sounds brutal, but it's a very precise lesioning using heat generated by a high-frequency current. We use it for things like facet joint pain and chronic back pain, or epidural steroid injections for radicular pain from a disc herniation.
And neuromodulation, spinal cord stimulators.
That goes right back to the gate control theory we discussed at the very beginning. You implant electrodes in the epidural space over the dorsal columns. They deliver a small electrical current that stimulates the large A-beta fibers.
Creating a tingling sensation.
Paresthesia, yes. And this sensation masks the pain signal traveling up the C fibers. It closes the gate electrically.
And finally, we shouldn't ignore the non-pharmacological stuff in our answer.
Never. A good answer is a holistic one. Mention 10NS, transcutaneous electrical nerve stimulation, which works on the same gate control principle. Mention psychological therapies like cognitive behavioral therapy, which are vital for chronic pain. And of course, physiotherapy early mobilization prevents the secondary pain of stiffness and muscle atrophy.
So we have all these tools, a huge toolkit. How do we integrate them? Section 13 implies we need a perioperative strategy.
The strategy is start before the start. Timing is everything. You give your oral pre-medication like gabapentin, acetaminophen, maybe a COX-2 inhibitor 1 to 2 hours before surgery.
So they're already working when the patient hits the table.
Exactly. Then you perform your regional block before the surgeon makes the incision.
And the choice of technique must be procedure-specific.
Absolutely. One size does not fit all. You wouldn't put an epidural in for a carpal tunnel release. For a thoracotomy, an epidural or a paravertebral block is the gold standard. For a total knee, maybe a femoral or an adductor canal block. For a laparoscopic cholecystectomy, perhaps just port site infiltration with local and some NSAIDs is enough.
Patient factors matter too, of course.
Hugely. If the patient has renal failure, you must avoid NSAIDs. If they're elderly and frail, you'll use much lower doses of opioids. If they have obstructive sleep apnea or OSA, you must minimize opioids to prevent airway collapse post-operatively.
So for an OSA patient, your multimodal game has to be incredibly strong.
It has to be airtight. You're relying heavily on regional techniques, IV lidocaine, dexmedetomidine, anything to avoid giving them a big dose of morphine that might make them stop breathing in the recovery room.
This leads us to the concept of multimodal analgesia itself. This is an exam favorite. How do I define it to get full marks?
Multimodal analgesia is the use of 2 or more classes of analgesics that act by different mechanisms of action.
And the math is 1 + 1 = 3. It's not additive, it's...
Synergistic.
Yeah.
That is the key word. By attacking the pain pathway at multiple points simultaneously. Transduction with NSAIDs, transmission with local anesthetics, modulation with opioids and alpha-2 agonists, perception with paracetamol, you get better pain relief with lower doses of each individual drug.
And consequently lower toxicity and fewer side effects.
Exactly. Less nausea from opioids, less kidney risk from NSAIDs, less sedation because you are using just a little bit of everything instead of a lot of one thing.
This all ties into the modern concept of ER's enhanced recovery after surgery.
Multimodal analgesia is the absolute cornerstone of ERS. You cannot have an ERAS protocol without a robust multimodal analgesia plan.
Because if pain isn't a barrier,
The patient gets up and walks sooner. If they walk sooner, they breathe deeper, which means less risk of pneumonia. They get their bowel function back faster, which means less post-op Ileus. It reduces the length of stay, which makes the hospital administrators happy, and more importantly, it gets the patient back to their normal life faster.
right, we are in the home stretch, Part E exam integration. I need to visualize how to put this on paper. How do I present this clearly?
Visualizing tables is hard on audio, but let's paint the picture for you. You need a comparison table in your long answer for preemptive versus preventive.
Okay.
Column 1, preemptive, focus. Pre-incision only, very narrow. Evidence, mixed or equivocal.
Got it.
Column 2, preventive, focus. Entire perioperative period, broad, evidence. Strong, especially for reducing chronic pain. And you'd add that it includes coverage for post-op inflammation.
And a second table for opioid-centric versus multimodal.
Yes. Column 1, opioid-centric. High side effect profile, risk of rapid tolerance, potential for opioid-induced hyperalgesia.
Right.
Column 2, multimodal. Opioid sparing, better safety profile, protects organ function, synergistic effect. Drawing those simple tables in your answer sheet breaks up the text and shows the examiner you have structured thoughts. It's a high-yield technique.
Now let's talk about the traps. What are the common Viva questions that trip students up?
Trap 1. Is preemptive analgesia proven? We've touched on this. If you say yes, absolutely, you might lose marks for lacking nuance.
As the safe answer is.
The safe answer is strict preemptive analgesia trials, which only compared pre versus post-incision timing, were equivocal. However, the concept has evolved into preventative analgesia, which covers the whole perioperative period, and that is clinically proven to be effective.
Okay. Trap 2. What is the best analgesic?
A classic. There is no best. The answer is there is no single best agent. The best approach is a multimodal, procedure-specific, and patient-tailored one. Never commit to a single drug as the magic bullet.
And the biggest student mistake you see in written answers?
Focusing only on the drugs. They write pages about NSAIDs and opioids and ketamine, and they completely forget regional anesthesia. Regional is the most powerful tool we have for blocking transmission. If you write a 10-mark answer on modern pain management and don't mention nerve blocks and ultrasound, you will probably fail.
That's a strong warning. Let's talk diagrams. Examiners love diagrams.
They do. It shows you can synthesize information. You need 2 diagrams in your arsenal. Diagram 1, pain pathway. Draw a simple reflex arc. Label the 4 steps we talked about. Transduction at the periphery. Transmission along the nerve. Modulation in the dorsal horn. And perception in the brain.
And then annotate it.
Yes.
Yeah.
Then draw arrows showing where each drug class acts. NSAID at transduction, local anesthetics at transmission, opioids, alpha-2s, and ketamine at modulation. Paracetamol probably acts at perception. It shows a complete integrated understanding of pharmacology.
And diagram 2, timing.
This one is even simpler but very effective. Draw a horizontal line, a timeline, mark incision in the middle. Preemptive is a single arrow pointing to a spot just before the incision mark. Preventive is a thick bar that starts in the pre-op section, stretches through the intra-op section, and continues well into the post-op section. It visually demonstrates the difference in duration and coverage. It's an easy win.
That is brilliant. Visuals get marks. So let's summarize. If I had to bullet point the take-home message for the drive to the exam hall.
Okay, high-yield recap. Let's do it. 1. Pain is plastic neuroplasticity, and the wind-up phenomenon are real physiological changes in the spinal cord. 2. Preventative is superior to preemptive because it covers the entire injury period, including post-op inflammation. 3. Multimodal is mandatory, not optional. It's the standard of care to spare opioids and reduce toxicity. 4. Ultrasound has revolutionized the safety, precision, and scope of regional anesthesia. 5. And finally, regional anesthesia is the most effective way to block afferent transmission and prevent central sensitization from ever starting.
And if I need a concluding paragraph for my 15-mark answer, a knockout punch.
You write this, or something very close to it. In conclusion, modern pain management has evolved from a reactive, opioid-centric monotherapy to a proactive, multimodal, and preventive strategy. By targeting the pathophysiology of sensitization through a synergistic combination of pharmacologic and regional interventions, we not only improve acute postoperative pain, but also reduce the risk of chronic pain, minimize side effects, and facilitate enhanced recovery after surgery.
That is a solid distinction-level answer.
Absolutely. It covers the science, the clinical application, and the modern context. It ticks all the boxes.
Before we sign off, leave us with one final thought. A provocative question. Where's this going in the future?
I think it's going towards genomics. Pharmacogenomics. We already know some people respond to codeine and some don't based on their CYP2D6 enzymes. Will the future of pain management be genetic testing? Will we swab a patient's cheek in the pre-op clinic to see if they have a genetic predisposition to chronic pain or if they are a rapid metabolizer of opioids before we prescribe a single pill? Personalized pain medicine, based on your genetic makeup, is likely the next frontier.
That is a fascinating thought to chew on. And on that note, to all the post-grads listening, especially those prepping for the Gujarat University exams, you have the knowledge, you have the structure. Go crush that paper.
You've got this. Good luck.
See you on the next Deep Dive.